All right. We have one more person, but they have mentioned that they are seeing patients who are in hospital. So I think we'll go ahead and start in the interest of time, and then once they're able to join us, then we'll share the recording, possibly for the parts that they will have missed. So most welcome to your pediatric advanced life support training. My name is Edgar. So before we start, we are going to just do a brief introduction, just to tell you, as quality care, what we are currently doing. And then after that, we'll jump right into the training. So I should mention it feels kind of strange, considering tulikuwa maandamano just yesterday. But alas, this is the nature of life, so we continue. But anyways, yes, so Quality Care is an international training center that is under the American Heart Association. With the American Heart Association, we train courses like basic life support, we train advanced cardiac life support, we train pediatric advanced life support, excuse me. We also train first aid. Yes, specifically under the American Heart Association, those are the courses we train. So at any given time, we're always looking for instructors, because we have a lot of trainings ongoing at any given time. Specifically for basic life support, advanced cardiac life support, which is the most popular course we have. Pediatric advanced life support, not so much. We did a survey because we were also interested to kind of understand why. Most medics said they don't like dealing with children. They don't like dealing with the peds population. But we say, the cardiac arrest can happen in the peds population. And if you're the person who's attending to this patient at the time, could be it's not your department, but it happens sometimes. What you do really matters. So yes, we encourage everyone to do pediatric advanced life support as well. With time, we hope it will change, but for now, PALS pediatric advanced life support is kind of a niche course. It's kind of a niche course, I would say. But all the same, to become an American Heart Association instructor is super simple. You just need to get 100% in your pre-test, 100% in your post-test, that is pediatric advanced life support in this case. If you can manage to do that, we'll tell you, please come on board and join us as an instructor, because we have many trainings, but not enough instructors. For the purposes of today's class, we'll have Eric Menya. Eric Menya is a senior AHA instructor. He is a faculty member of the American Heart Association. He'll be taking us through the theory portion of the class today, as well as the practicals portion of the class tomorrow. We have a number of instructors. Here they are. If you come for other courses, probably you'll also get a chance to interact with them as well. As for location, this is where we are based. We are based at Fifth Avenue Suites, 8th floor at Quality Care. For the purposes of the practicals tomorrow, this is where the practical portion of the class will take place. Now, apart from that, we've been doing something called the Life is Why campaign. So the Life is Why campaign is essentially a campaign that is focused on trying to bring awareness to cardiac arrest. So cardiac arrest is the number one killer of both men and women in the world, more than all forms of cancer combined. So most cardiac arrests actually happen at home. So apart from just having medics train in basic life support, it's also important to have non-medics train in basic life support as well, because most cardiac arrests actually happen at home outside of hospital. Specifically in Kenya, currently we're focusing on hospitals because we also did a survey and we realized in level 5 hospitals, in level 6 hospitals, people who are working in ICU, people who are working in HDU, people who are working in the wards haven't done basic life support. Now, when a patient goes into cardiac arrest, you need to start CPR immediately. Not only CPR, but high quality CPR. If you do not, every minute that goes by, 7 to 10% chances of survival for this patient is gone. So high quality CPR being the focus of the Life is Why campaign. We've been going to hospitals, we've been going to universities, doing CMEs. So far, and also outside of Nairobi, we've been going to different counties, preaching the gospel, quote unquote, of the importance of high quality CPR. So in case you're working in a certain place and possibly they may benefit from learning about high quality CPR, I would encourage you to invite us because it's for free. It's for free. So please invite us. We'll come along and preach the gospel of high quality CPR because it's super, super important. Without high quality CPR, your patient will not survive. High quality CPR is a basis for saving any patient who goes into cardiac arrest. It's super, super important. So, in a nutshell, that is the Life is Why campaign. Importance of high quality CPR. We believe that every life is important, every life matters. And, if a patient goes into cardiac arrest, they deserve a fighting chance at the very least. So that is the Life is Why campaign. We hope you will go and spread the gospel of the importance of high quality CPR. So basic life support, advanced cardiac life support being the most popular course we have. So much so that sometimes we even have two trainings in a week. Um, we'll be having a training starting on Monday. We just had one which ended on Sunday. So they happen very, very frequently. In case you have a friend or a colleague who's interested, I'll share the posters in the group and I would request that you please share. Apart from basic life support, advanced cardiac life support, we also train clinical ECG interpretation training. If you work in the wards, if you work in ICU, if you work in HDU, super, super important to be able to look at the monitor and say, hey, the patient seems to be having a bradycardia. Let's manage this patient before they deteriorate. This patient seems to be having a tachycardia. Let's manage this patient. Allah, this patient doesn't have a pulse. Let's initiate high quality CPR and shout for help. This patient seems to have a shockable rhythm. Let's shock this patient as soon as possible. This patient has a non-shockable rhythm. Let's manage this patient. So clinical ECG, very, very important if you work in the ward, if you work in the HDU, ICU. Personally, I would say it's a must. We encourage you to also come and train. Next week, or is it after next week, we'll be having point of care ultrasound training. Point of care ultrasound training is for all medics. We've gone to hospitals where they have, two people in the radiology department. So you have like a number of patients who need to be scanned so that you know like what's happening in them so that you can make a clinical decision. But you can't because now you have to wait. So point of care ultrasound tries to address that. The focus of point of care ultrasound training is cardiac ultrasound, lung ultrasound, FAST, which is focused assessment with sonography and trauma and also vascular access. So if at any given time you found yourself like wanting to make a decision, but you need to send your patient to X-ray and then it takes time, then point of care ultrasound training is for you. It's for medical officers, it's for nursing officers, it's for clinical officers, it's for paramedics as well. So far, we have trained all of these cadres in point of care ultrasound training. Unlike X-rays, you don't expose your patient to radiation, so it's safer. It's more sensitive, so you're able to see more. And it's also, it's easier to use and more chap. You just need your probe, you need your phone or a tablet, you scan the patient, you look at the image, you interpret, yes, and you manage your patient based on that. So point of care ultrasound training, we hope you will consider training in it. The next one will be in September. Pre-hospital trauma life support, abbreviated as PHTLS, is also a training we also offer. So PHTLS is for the medic who are amechoka na 9 to 5. You're looking at locums and you're like, where is he? Nimechoka kidogo. So PHTLS is also for the medic who deals with a lot of trauma patients. I would say just like basic life support, advanced cardiac life support is a basic requirement when you're looking for a job in hospital. Pre-hospital trauma life support is a basic requirement when you're looking for a job in the pre-hospital setup. So what does this look like? Perhaps you want to become a flight doctor with AMREF. Pre-hospital trauma life support is a basic requirement. Perhaps you want to work with Médecins Sans Frontières. Pre-hospital trauma life support is a basic requirement. You're looking for a job at the United Nations. Pre-hospital trauma life support is a basic requirement. You want to become a medic on board of these vessels, which take people on holiday. You know, those big cruise ships, they're always in need of medics. Pre-hospital trauma life support is a basic requirement. So for medics, there are so many options. You don't necessarily have to work in the traditional 9 to 5, but you have to have the necessary certifications and also the will to apply for them, to look for these opportunities and apply for them. They are there, but you kind of have to be in a specific space. And lastly, we also offer pediatric advanced life support, of course, for the medic who deals with the peds population. Super important. I'll share the poster in the group in case you have a friend or a colleague. Highly appreciate if you share. So here we have our last point of care ultrasound training. Here we are doing vascular access. You've been looking for the patient's vein and you just can't find it. So you just come with your probe, your ultrasound gel, your plug, inside the needle end where you have access. Yes. So point of care ultrasound is very handy. Here we are doing lung ultrasound. Here we're doing high quality CPR in in the middle of nowhere. It was deep in the woods. We were training soldiers on how to do high quality CPR. Very important also for non-medics. On the left, we are training basic life support in a place called Wadi Degla. It's a sports club where families come together and something happened, like a child nearly drowned, and so they needed to actually assess and manage these patients, but they couldn't. No one knew what to do. But luckily, there was a medic who was there. There's a medic who was there. They intervened and they saved the child's life. But it got them thinking that what would have happened in case the medic wasn't there, which triggered them to now come and train in basic life support. On the right, advanced cardiac life support training happening. Here we have pre-hospital trauma life support. Most of the damage which is done to a patient is done after an accident occurs. So in moving the patient, you want to immobilize the spine and move them in a way that will not do more damage to the patient. But most of the times after an accident has happened, then patients anabebwa tu anaingishwa kwa gari, which is not good. So in case you know someone who works in the pre-hospital setup, please encourage them to do pre-hospital trauma life support. We also have a number of partnerships, one of which is MSSI. We also train outside of Kenya. MSSI, Medical and Surgical Skills Institute, is in Ghana. We have also partnered with Avant Healthcare Professionals. So with Avant, we help nurses go abroad. So in case you have a nurse who has gotten tired with living in Kenya, we encourage you to tell them to come and, just inquire what is the process, how long does it take, and if they're interested, they can start the process. Global Ultrasound Institute, in short, known as GASI, not GUSI, because ultrasound, so GASI is what they say. We train point of care ultrasound training in partnership with them. So certificates come from Global Ultrasound Institute. They're based in America. They train in America, they train in Asia, they train in Europe, and now they train in Africa with us as well. So certification comes from the Global Ultrasound Institute. We have partnered with all of these other companies, but in the interest of time, I won't speak more. Okay, can speak at a later time. We also sell medical equipment. Automated external defib is very important. For the peds population, you'd want to use the manual defibrillator. But in case the manual defib isn't there, then you just use the automated external defib. Now, high quality CPR is very, very important. But if your patient doesn't have a pulse, that means they're in cardiac arrest. They either have a shockable rhythm or an unshockable rhythm. If they have a shockable rhythm, for every minute that goes by without shocking this shockable rhythm, an additional 7 to 10% is gone for this patient. So in addition to high quality CPR, as part of the Life is Why campaign, we also emphasize early defibrillation. Early defibrillation just as important as high quality CPR, because without it, you can do high quality CPR forever, but unfortunately, if this patient has a shockable rhythm, you will still lose your patient. So we hope after doing this course, you go back and tell people high quality CPR is super, super important. Having an AED at the very least is super, super important. But for the pediatric population, recommended is the manual defib. For the manual defib, we have two types. We have one which can pace and one which can't pace. In the hospital, you'll never miss a patient who you have to pace. So it's always important to get a manual defib which can pace. Difference in cost ni kidogo kiasi, but kidogo is relative. Cost for the one which can pace is 550,000. The one which can't pace is 500,000 shillings. This is what we'll be using for the training tomorrow when it comes to management of arrhythmias. Automated external defib, we sell the Philips FR2 AED, military grade, dust-proof, waterproof. Very nice defib which will last you for a minimum of 10 years. Very nice automated external defib. Cost for this one is 250,000 shillings. So that when you approach the management, you tell them, I have this one in mind, this is the cost, and then they do their research. If they want a more advanced one, there are more advanced AEDs out there, but of course, the more advanced they are, the more expensive they are. So that's also something to have in mind. We also have advanced clinical ECG interpretation course in case you work in the ICU, HDU, you work in wards, or you may just want to improve, the amount of knowledge you have. Then we encourage you to do advanced clinical ECG interpretation training. Point of care ultrasound training, deadline for booking passed quite a while ago. Not recommended to join this one because of the amount of reading which is required. But in case you want to, you still can. So we encourage you, or you can get the content, start reading, and see if you can join this one. If not, join the next one. BLS, ACLS, we have a training which starts on Monday. After that, we'll have the next one on the second week of July. Pediatric Advanced Life Support, we'll have a training in July. I'll share the poster in the group. In case you have a friend or a colleague, please share. We also have Training of Trainers course. Training of Trainers course is for the person who wants to also become an instructor. Pass mark for Training of Trainers course is of course 100%. And also you have to be passionate about sharing knowledge and skills. Those are the only requirements essentially to become an instructor. Pre-hospital trauma life support, we are actually supposed to have one this week. Yes, but this one will be too soon. I'll share the poster for August. In case you're interested, tunakukaribisha sana. Yes, last but not least, American Heart Association guidelines. I see Ruth alifall by the wayside. Ruth hayuko class. Let me just message her and say yes, we're now starting. Welcome. Please join back. We are now starting. All right. So American Heart Association guideline. Certificate comes from the American Heart Association. As per usual, you have to pass the theory and the practicals portion. So theory is in the form of multiple choice questions. We'll do the theory exam tomorrow. The first thing, once we reach for practicals, we'll start with the theory exam. Pass mark for pediatric advanced life support, similar to BLS and ACLS, is 84%. 50 multiple choice questions for pediatric advanced life support. Pass mark is 84%. So means that you have to get 42 out of 50 to pass. In case you don't pass your first attempt for theory, you get a second attempt, but after practicals. But we hope you pass your first attempt tomorrow. Yes, we hope you pass your first attempt tomorrow. So once you pass your theory exam, we go into practicals. So practicals is either pass or fail. Tomorrow practical assessment will be in the form of continuous assessment, starting from pediatric BLS all the way to pediatric ALS. So is a bit of a lot of content. We'll go through it today. In case during the continuous assessment you don't pass, I believe there'll be a final assessment where you'll be able to redeem yourself. But Instructor Eric will tell us more once he comes and introduces himself. All right. So thanks so much for listening to me. My name is Edgar. This is our website. This is our Facebook page. When you come tomorrow, we'll be taking pictures of the practicals and posting online. That is our Facebook, our Instagram, our LinkedIn, and our TikTok as well. So in case you're on the run from the FBI, please let us know so that we don't post you. But the purpose of this is, of course, marketing, so that a friend or a colleague sees you training, they also become inspired and they say also, okay, even me, let me go ahead and train. One day, one time, possibly you're at a locum together or you're just at work, a patient comes in, they become unresponsive, and everybody works in a chap way. They're confident in what they are doing. The management of the patient is good, and you save your patient's life, which is the ultimate goal for the life support courses, basic, advanced, and pediatric as well. So we welcome you so much to the pediatric advanced life support training. We'll go ahead and start, but before we do, I would request Eric just to say hello, and then after that, I will play the pediatric BLS videos. So Eric, karibu sana, please say hello, and then I'll play play some of them.
Yeah, good morning. For some reason, I can't hear you.
Oh, good morning, good morning.
Yeah,
So, so
thank you.
Thank you very much, Eric. Eric will be our instructor for today. So I'll start by playing a pediatric BLS. I request that you please take down some notes, and then after the video, we will have a discussion on the same. So most welcome.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. Of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording.
Hello, and welcome to the American Heart Association's Pediatric Advanced Life Support courses.
This course will consist of pediatric basic life support review and skill checks, followed by the systematic approach to assessment, respiratory emergency management, and shock emergency management.
We'll also address cardiac emergencies and post-cardiac arrest care. Each section will have video components, as well as group discussion, hands-on practice, and skill checkoffs to assess what you will have learned.
Teams will be evaluated as a group.
Please remember, as the team leader, you are encouraged to use and utilize your team and their feedback to provide the best possible outcome for your patient.
There will also be an open resource exam with a required passing rate of 84%. Good luck. The work you do matters. The skills you learn can save lives.
Thank you for choosing the American Heart Association.
We would like to thank the following hospitals for providing patient video:
The Children's Hospital of Philadelphia,
Seattle Children's Hospital,
Children's Hospital and Medical Center of Omaha,
and Arkansas Children's Hospital.
Thank you.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. Of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording. Sudden cardiac arrest occurs without warning or within just a few minutes after symptoms appear. On any given day and at any given time, you could encounter a victim of cardiac arrest. And with the training you received today, your actions can give the victim the best chance of survival. But first, let's talk about the pediatric chains of survival. The causes and treatment of cardiac arrest differ between in-hospital cardiac arrest, also called IHCA, and out-of-hospital cardiac arrest, also called OHCA. Therefore, specific chains of survival have been created for each of these populations. There are 6 links in each chain. The first link in the pediatric chain of survival is prevention and preparedness, including responder training, early recognition of cardiac arrest, and rapid response teams. The second and third links are activation of the emergency response system and high-quality CPR, including early defibrillation. Next comes advanced resuscitation interventions, followed by post-cardiac arrest care. The sixth link in both the OHCA and IHCA chains of survival is recovery. This chain is a useful metaphor to understand the connection and flow between the stages of emergency cardiovascular care. To begin training, we'll focus on individual skills that rescuers perform. It's most effective to perform CPR as a team. However, to be an effective team member, you'll need to possess the individual skills of CPR. So, we'll start there. As a healthcare provider, your first step is to verify scene safety. Then, tap and shout to check for responsiveness.
Hey, are you okay? Are you okay?
If there is no response, you should shout for nearby help or activate the emergency response system in your workplace.
Activate the emergency response and get an AED.
Check for a carotid pulse. Locate the child's trachea by using 2 or 3 fingers, and then slide your fingers into the groove just to one side of the trachea where you can feel the carotid pulse. The technique of feeling for the carotid pulse is usually easier to perform on the side closest to you, the rescuer. Check for breathing by scanning the child's chest, looking for chest rise and fall. You can scan for breathing and check a pulse simultaneously to minimize time before the first compression. The check for breathing and a pulse should take at least 5 but no more than 10 seconds. If you observe no breathing or only gasping and you do not feel a pulse within 10 seconds, start CPR immediately. A bit later in this course, we'll talk about what to do if someone is unresponsive, is not breathing, but a pulse is felt. But right now, we're assuming you don't feel a pulse, so you need to do compressions. By starting compressions, you are initiating the CAB sequence, or compressions, airway, and breathing sequence. After you give compressions, open the child's airway and deliver breaths. It's important to minimize interruptions in chest compressions to less than 10 seconds. Each time you stop compressions, the blood flow to the heart and brain decreases significantly. Once you resume compressions, it takes several compressions to increase blood flow to the heart and brain back to the same levels. So any interruption in chest compressions can result in low blood flow and minimize the chance of the return of spontaneous circulation, or ROSC. Breaths should be given with a barrier device, such as a pocket mask or face shield, during one rescuer CPR. In some circumstances, a workplace may have only a bag mask device available. In these instances, you may complete your skills test with a bag mask device. In the clinical setting, a rescuer may not be able to deliver 2 breaths within 10 seconds when using a bag mask device during one rescuer CPR. The American Heart Association and BLS guidelines define anyone from age 1 year to puberty as a child. Under these guidelines, puberty is defined as chest or underarm hair on boys and any breast development on girls. When you're performing compressions on a child, it's fine to use 1 or 2 hands, whichever works for you and allows you to provide deep, effective compressions. To be effective, your compressions must go to a depth of at least 1/3 the depth of the child's chest, which equates to approximately 2 inches or 5 centimeters, and the chest must recoil completely between compressions. With single rescuer CPR, you'll always use a compression to ventilation ratio of 30 compressions to 2 breaths. However, when performing 2 rescuer CPR on a child, the ratio changes and should be 15 compressions to 2 breaths. Before we start, you need to make sure that the child is on a firm, flat surface lying face up. Quickly move bulky clothing out of the way that is covering the child or infant's chest so that you can locate appropriate hand or finger placement for compressions. If a person's clothes are difficult to remove, you can still provide compressions over clothing. If an AED becomes available, remove all clothes that cover the chest. AED pads must not be placed over any clothing. To begin, place the heel of one hand on the center of your mannequin's bare chest, over the lower half of the sternum. Place the heel of your other hand on top of the first. Make sure that your shoulders are directly over your hands, with your elbows straight. And when we start, remember to push straight down on the sternum to get adequate depth. When you push, push hard and fast. There are some differences in sequence for a single rescuer of a child, depending on whether the child was found in arrest or the arrest was sudden and witnessed. If you do not witness the arrest and you're alone and have no mobile phone, you should shout for help. But perform 5 cycles of CPR before you leave the child to activate the emergency response system and get a nearby AED. Then return to the child to perform CPR and use the AED. However, if you are alone without a mobile phone and you do witness a child suddenly collapse, you should leave the child to quickly activate the emergency response system and get a nearby AED, and then return to the child to perform CPR and use the AED. Of course, when there are multiple rescuers, the first rescuer should remain with the child to begin CPR, while other rescuers activate the emergency response system and retrieve the AED. Now, we'll talk about the skills for 1 and 2 rescuer infant CPR. But this time, we'll first learn to check for a brachial pulse, followed by infant compressions, and then we'll go on to the breaths with the bag mask device. Finally, we'll combine those for practicing two-rescuer infant CPR. To check an infant's brachial pulse, first place 2 or 3 fingers on the inside of the upper arm, between the elbow and shoulder. Then, when attempting to feel the pulse, press the index and middle fingers gently on the inside of the upper arm for at least 5 seconds and no more than 10 seconds. If there is no pulse, or if the heart rate in an infant or child is less than 60 beats per minute, with signs of poor perfusion despite adequate oxygenation and ventilation, begin compressions with the ventilation. To begin CPR, place the tips of 2 fingers or 2 thumbs on the sternum in the center of the infant's chest, just below the nipple line. Be careful not to press on the bottom of the sternum. With your hands in the correct position, push hard and fast to a depth of at least 1/3 the depth of the chest, or approximately 1.5 inches or 4 centimeters. And the rate needs to be 100 to 120 compressions per minute. After each compression, allow the chest to recoil completely. We'll pause here and practice. Now it's time to practice two-rescuer infant CPR. When you perform two-rescuer CPR, the person doing compressions should use the 2-thumb encircling hands technique. Here are the steps. Place both thumbs side by side in the center of the infant's chest, on the lower half of the sternum. There should be no pressure placed on the tip of the sternum, and your thumbs may overlap in very small infants. Then, encircle the infant's chest and support the infant's back with the fingers of both hands. In this position, use both thumbs to depress the sternum at least 1/3 the depth of the infant's chest, which equates to approximately 1.5 inches or 4 centimeters. Let's take note of a key difference between 1 and 2 rescuer infant CPR. Instead of a 30-to-2 ratio in a 1 rescuer situation, you'll use the ratio of 15 compressions to 2 breaths. We'll pause here and practice. Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. Of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The successful resuscitation of a patient in cardiac arrest requires a coordinated team effort. Effective teams have providers with well-defined roles, and they work together in a dynamic and timely fashion to prioritize and complete critical tasks. The team leader is responsible for coordinating these tasks and ensuring that clinical care is delivered according to American Heart Association guidelines. Delivering high-quality CPR while minimizing pauses optimizes outcomes after cardiac arrest. But because of competing priorities, it can be difficult for team leaders to continuously monitor and provide feedback on CPR quality. The CPR coach is a new role within the resuscitation team, and it's designed to address these difficulties and promote the delivery of high-quality CPR. The presence of a CPR coach allows the team leader to focus on other elements of cardiac arrest care. Whether you're a basic life support provider or an advanced life support provider, the role of CPR coach exists to help you and your team deliver high-quality CPR. The most effective way to implement the role of a CPR coach is with a real-time audio-visual feedback device. We'll discuss some of the functions of the CPR coach and how they use feedback devices. First, let's talk about the team layout when using a CPR coach. CPR coaches should stand across from the compressor, always in the compressor's direct line of sight. CPR coaches should also stand next to the CPR feedback display, which is often located on the defibrillator, so that they can effortlessly redirect the compressor's attention to the data provided by the feedback device. Now that the CPR coach is in place, they should verbalize the data from the feedback device, providing corrective and positive feedback, such as push harder or your rate is good.
Great job. You're right on target.
In addition to giving corrective feedback, CPR coaches should give mid-range targets so that providers can focus on a precise metric. An example of this would be coaching the compressor to target a rate of 110 compressions per minute, taking the average between the recommended range of 100 to 120 compressions per minute.
And now you're too fast. Target heart rate is 110.
The CPR coach should also coordinate the initiation of CPR and pauses in CPR. These actions can include initiating CPR, placing a CPR board if needed, analyzing the rhythm, switching compressors, defibrillating, or intubating the patient. The goal of the coach is to keep all pauses to 5 seconds or less when possible.
Switch.
Okay, that BF, go ahead
Hover.
and chart and shock.
Clear. Shock. Resume.
Except for intubation. Intubation should be performed by skilled providers, ideally without stopping compressions.
Okay, through the cords.
But if it's necessary to pause for intubation, the pause must be for 10 seconds or less.
I'm still having trouble. Go ahead and pause CPR. Okay, there we go. Through the cords. Continue.
If intubation can't be accomplished in 10 seconds or less, the team should continue compressions with bag mask ventilation. Being an effective CPR coach takes practice and training. If you'd like to learn more about how you can incorporate the CPR coach role into your resuscitation team, please ask your instructor for more information. The bag mask device consists of a ventilation bag and a face mask, and it comes in a variety of sizes. You can also use supplemental oxygen with the bag mask device. To begin, position yourself directly above the child's head. You'll use the EC clamp technique to hold the mask in place. To do this, place the mask on the child's face, using the bridge of the nose as a guide. Use the thumb and index finger of one hand to make a C to press the edges of the mask to the face. The remaining 3 fingers of your hand should form an E to tilt the head back, lift the jaw, and open the airway. Make sure you squeeze the mask with your thumb and index finger while lifting the jaw to achieve an airtight seal between the mask and the face. You'll squeeze the bag with your other hand. If the chest does not rise with each breath, then you're not providing adequate breaths. If this occurs, readjust the mask, reposition the head and neck, and attempt to ventilate. And then, only if necessary, administer a larger amount of air. Make sure to deliver each breath over 1 second with just enough volume to make the chest rise. Delivering breaths in this way will reduce the chance of gastric inflation, which is air going into the child's stomach instead of the lungs. Gastric inflation can cause vomiting and possible aspiration. If you have multiple rescuers, the most effective way to deliver breaths with a bag mask device is to use the 2-person technique. For this technique, one rescuer focuses on keeping the airway open and securing the mask, while a second rescuer squeezes the bag to deliver breaths, just enough to cause the chest to rise. The first rescuer will use both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C to seal the mask against the face. And the 3 remaining fingers of each hand will form an E, lifting both sides of the jaw into the mask. Be careful not to press too hard on the mask, because this could push the child's jaw down and block the airway. Another way to deliver breaths is with an advanced airway. Devices such as a laryngeal mask airway, a supraglottic airway device, and an endotracheal tube are advanced airways that are more secure for providing breaths. These devices help prevent gastric distension and airway obstruction. Placing these devices requires special training that we will not cover in this course, but you should know how to give breaths with an advanced airway in place. During CPR, when one of these advanced airways is in place, the ratio of compressions to breaths changes. Instead of giving 30 compressions and 2 breaths, you'll perform continual compressions at a rate of 100 to 120 per minute and target a respiratory rate range of 1 breath every 2 to 3 seconds. There are no pauses in compressions to give breaths when you're using an advanced airway, because these allow blood flow to the heart and brain to remain high. Now, let's focus on the use of an AED. You'll need to familiarize yourself with the AED device that you'll be using today for your training class. There are some differences for the use of an AED for infants and children under 8 years of age. Some AEDs can deliver either an adult or child shock dose. The child dose is used for children under 8. If you are using a pediatric capable AED, it will have features allowing a child-appropriate shock. But the type of feature available depends on the type of AED you're using. Your AED may include smaller size pads designed for children under 8 years of age. If it does, use them. If not, use the adult pads, making sure they don't touch or overlap. However, you should never use the child pads for an adult. The shock dose delivered by child pads is too small for an adult, and it will likely not be successful. It's better to provide high-quality CPR than to attempt to shock an adult victim with child pads. Some AED pads recommend a different pad placement for infants and children, placing 1 pad on the chest and 1 on the back. Follow the pictures on the pad packages for proper pad placement. Although AEDs may differ slightly, there are 4 universal steps for operation: turning on the AED, attaching the pads to the patient, analyzing the heart rhythm, and delivering a shock, if indicated. To begin, turn on the AED. Simply open the carrying case or the top of the unit and power on the AED. Some devices will power on automatically when you open the lid. Either way, after the AED is on, attach the pads to the child's chest by using the diagrams on the pads for correct placement. Some AEDs may have adult and pediatric pads. Be sure to use the adult pads on anyone 8 years of age or older. If you're not sure of the child's age, use the adult pads. You may also need to plug in the pads for certain models. Following the pictures found on the pads, attach the adhesive pads to the child's bare chest. Place 1 pad on the child's upper right chest, directly below the collarbone, and the other to the left side of the left nipple. After the AED is turned on, some units will tell you to press a button for the device to analyze the heart rhythm. Others will analyze the rhythm automatically. The AED may take about 5 to 15 seconds to analyze the rhythm. The AED will deliver an audible prompt when it's ready to analyze the rhythm, followed by a prompt to clear the child or infant. The rescuer should strongly repeat the command to clear, checking visually to be sure that all rescuers and bystanders receive the command. Once the AED completes its analysis, if a shock is advised, it will charge.
Shock advised. Charging. Do not touch victim.
Clear.
Most devices will prompt again to clear the child or infant. Some devices, however, will allow chest compressions to be performed during the charge phase. Providing compressions during the charge phase is optimal, but be familiar with the devices you have access to so that you'll know whether to provide compressions during this phase. The rescuer should again repeat the clear command to those nearby and visually confirm that no one is touching the child, not even the person in charge of giving breaths. Press the shock button. The shock may produce a sudden contraction in the child or infant's muscles.
Push the shock button now. Shock delivered. Resume chest compression.
1, 2, 3, 4, 5.
After the AED gives the shock, resume CPR immediately, beginning with chest compressions. Do not remove the AED or turn it off. The device will repeat the analyze and shock cycle about every 2 minutes. Follow the voice prompts of the AED. If at any time the AED indicates that no shock is advised, immediately start chest compressions. If the child has water on the chest, this can be a problem. It could allow the shock to travel through the water between the pads, ultimately preventing delivery of an effective shock dose to the child's heart. If someone is lying in water, you should quickly move them to a dry area. However, if the child is lying on snow or in a small puddle, you may use the AED. And if the chest is covered with water or sweat, wipe the chest before attaching the AED pads. But wipe the chest quickly. It doesn't have to be completely dry. We'll pause here to allow you to get familiar with the AED in your class today. Your instructor will show you all that's included in the kit and demonstrate the correct way to place the pads on the child.
Okay. Morning, Daniel.
Morning.
Yes. Ruth, good morning.
Morning.
Yes. Thank you for joining us this morning for PALS. We will do ELS recap. And because we are not really planning about BLS, we are just going to recap on the BLS sequence, for the chain of survival. So maybe before I continue, I just need to get a feel as to our background a bit. So Daniel, you work in a pediatric setting?
I work in the OPD, in the level 3 D OPD and in OPD and inpatients.
Okay. Ruth?
I work with the outpatient department, but I am soon branching into fully pediatrics outpatient, plus or minus the pediatric ICU.
Oh, all right. So essentially, before we discuss the sequence, usually we talk about the chain of survival. And in hospital, when it comes to the in-hospital cardiac arrest chain of survival, we say the first
You
link.
don't care about them.
Yes, Edgar. The first link in the chain is early recognition and prevention. Early recognition and prevention is the first link when it comes to in-hospital cardiac arrest. So we must prioritize recognizing patients who are at risk of a cardiac arrest early, and we intervene before they actually go into a cardiac arrest. And part of recognizing early is being able to thoroughly do a thorough assessment of the patient. And what we are about to get into after the BLS is how to do your assessment. So we'll touch on that. This is then followed by activation of the emergency response team, followed by high quality CPR, which is what we'll try and remind ourselves over. Daniel, how recent is your ACLS?
Mine is 2 years old now.
2 years.
Expired, rather. Expired.
You did it with us?
Yeah, I did it with you.
Okay.
Yeah.
Ruth?
I did mine last year, February.
With us?
Yes. Yes.
Okay. All right. So early recognition and prevention, activation of the emergency response team, high quality CPR, because we say for every minute that passes without high quality CPR, a patient's chances of survival will reduce by 7 to 10%. This is followed by advanced resuscitation or advanced life support. And this is where a PALS provider would fit in. So you take over from the BLS provider and you provide advanced life support, followed by post-cardiac arrest care, and then recovery. Now, if we are talking about a cardiac arrest that has occurred or is likely to occur out of hospital, the first link in the chain is usually prevention. So here the emphasis is on, okay, it's okay. Here the emphasis is on educating these mothers on how to, or caregivers, on how to prevent cardiac arrest. One of the most common causes of cardiac arrest in pediatric patients is choking. So how do they relieve choking in a child? How should they relieve choking in an infant? Those are skills that you need to teach these mothers on or caregivers on. How to ensure their home is a safe space for a pediatric patient. So safeguarding against home accidents or baby proofing if you wish. All right. So that's all under prevention. Now, in case a cardiac arrest does occur, they need to have the numbers activating emergency medical services. Ruth, do you have these numbers?
I do. You shared them with us last session and then also yesterday.
Okay.
They were everywhere on social media.
Oh, really?
Yeah.
Interesting. That's good. Daniel, you have the EMS numbers?
Not really.
We can't hear you. Perhaps your I think your microphone volume or something. So Daniel says, not really. Okay. So we have Red Cross 07 00 395 395. We have Rescue by Flair 0714 911 911. We have AAR ambulance 0725 225 225. We have St. John as well 0721 225 285. So save these numbers on your phone and share them widely. Share with your loved ones, share in whichever groups you're in, so that guys know who to call in case of an emergency. Of course, the Nairobi County toll-free number, I know Ruth doesn't have this one. So toll-free number for Nairobi County is 1508. So we can call these numbers in case of an emergency. But more to the point, share these numbers with the caregivers so that they know who to call in case an emergency does occur. Good. After activation of EMS, the next link in the chain is usually high quality CPR. So in addition to sharing these numbers with them, we also need to train them on how to provide high quality CPR. This is followed by advanced resuscitation or advanced life support, followed by post-cardiac arrest care, and then recovery as the last link. So those are the links in the chain of survival for pediatrics. Now, when it comes to talking about the BLS sequence, I'm sure we recall the sequence is SSS CABD. So SSS CABD. Okay. Now, the first S is for safety. And here we are saying rescuer safety, victim, and scene. And before we even discuss the sequence in detail, it's important to recap the age groups. The child is 1 year to puberty. Anyone 1 year and above to puberty or signs of adolescence is treated as you would a child. The infant is anyone less than 1 year, except or excluding newborns in the newborn unit. Okay, so safety remains the same as you would for the adult. Ensure rescuer is safe, victim is safe, scene is safe. Stimulate. Now in stimulation, we say do verbal and tactile, especially for the child. Tactile in the child means tap the shoulders. Tactile in the infant means tap the heel. So we tap the heel of the infant. The third S, once you've stimulated, if they are unresponsive, shout for help. Your shout for help needs to capture where you are, what has happened, and what you need. However, in pediatrics, it matters whether it is witnessed. So if you saw the child or infant becoming unresponsive, proceed and shout for help. Because you know, until a few seconds ago, their brain was well perfused. Now, if it is unwitnessed, meaning you did not see this child becoming unresponsive, you found them in that state, or the mother called you to an unresponsive baby, then that is unwitnessed. You must be the one to witness. If you do not witness, assess the need for CPR. So assess the child. If they need CPR, do CPR for 2 minutes. If you are alone, then proceed to shout for help. So if you are alone, question becomes, did I witness it or not? If you witnessed, proceed and shout for help. If you did not witness, first prioritize CPR if they need it for 2 minutes, then proceed to shout for help. C is for circulation. Here we are saying check for pulse. And breathing for 5 to 10 seconds. So at least 5 seconds, not more than 10 seconds. For the child, we check the carotid or femoral. For the infant, we check the brachial. In both age groups, if there's no pulse or it is less than 60 beats per minute with signs of hemodynamic compromise, start CPR. So if there's no pulse or pulse is less than 60 beats per minute, start CPR. And when it comes to high quality CPR, the first thing we must do is landmark in order to know where to place the heel of our dominant hand. So we say target the lower half of the sternum. Now, because this age group is yet to experience breast development, the nipple line is a reliable landmark or line to use to identify the lower half of the sternum. Number 2, technique. If it is a child, the technique we use can be one hand or we can use 2 hands. Depends on the size of the child and the size of the rescuer. So if the rescuer is huge, child is tiny, 1 hand will suffice. Rescuer is tiny, child is huge, 2 hands will be needed. If it's an infant, the technique we use depends on the number of rescuers. For one rescuer, we use 2 fingers or thumb and suckling technique. 2 fingers or thumb and suckling technique. If you are 2 rescuers or more, so greater than or equal to 2 rescuers, we do thumb and suckling strictly. So thumb and suckling technique is the approach to use. Number 3 is the rate. Rate needs to be 100 to 120 per minute. And how do we pace ourselves to ensure 100 to 120 per minute truth?
How you ensure your rate is like that. There's that app. There's a metronome app, I remember.
Have you used it?
Practically in my setup so far, no.
How come? How come? Where is the
happens
challenge?
so fast. It happens
It
very
happens so
quickly.
fast.
Yeah, so you don't have the time to access your phone to be able to open the app and stuff. So what we usually do is we count over a minute.
How? A book count?
We go 1 and 2 and 3. One. No, wait, what? Let me remember. Yes, 1 and 2 and 3 and 4, 5 and 6 and 7 and 8, 9 and 10.
7, 8, 9
Like you
and
pace
10
with the
and
way
10.
someone could clap to pace you.
4, 5 and 6 and 7 and 8, 9 and 10. 1 and 2 and 3 and 4, 5 and 6 and 7 and 8, 9 and 10. 1 and 2 and 3 and 4, 5 and 6 and 7 and 8, 9 and okay, fine. But I don't know. You work in a setting where you're not allowed to have your phone.
It's not about, okay, kind of yes, but then at the same time, it's also ones whereby, like, the first thing that occurs to you in a cardiac arrest is not to access your phone.
Yeah.
So you
All
just
right.
go with your instinct and you start your CPR, but there's always a timer, so they can be able to time you to tell you
So
if you're doing things.
would they be in a position to turn on the metronome?
If they had it,
Like,
yes.
once help arrives.
Yes, if they have the app, yes.
So why don't we share this knowledge across widely? Whenever a cardiac arrest occurs, we know what that is, and we try and adopt and see if it will change outcomes for us. Now, other than the metronome, you can also sing the song. You know the song?
No.
Staying Alive.
No, I don't know the song.
Daniel, you know the song?
I think I do. But ni ile ya kitambo, si ndio?
Ile ya kitambo by Bee Gees.
Yeah, I know it.
Yeah, but don't get to the point where they say staying alive. No, just staying alive, staying alive. That's going to help you pace yourself. So, but preferably, let's use a feedback device. So the metronome is a good one to use. Yeah. Now, ratio. The ratio depends on number of rescuers. One rescuer, ratio is 30 to 2. 2 rescuers, ratio is 15 to 2. This change is because in pediatric patients, the commonest cause of collapse is usually respiratory issues. So you want to give them more breaths. So hence the ratio of 15 to 2, to give more breaths when possible. Depth. If we are talking about a child, the depth is 2 inches or 5 centimeters. If we are talking about an infant, the depth is 1.5 inches or 4 centimeters. Number 6, allow for complete chest recoil. Allow for recoil. The other aspects remain similar to the other. So allow for recoil. Number 7, minimize interruptions. To less than 10 seconds or equal to 10 seconds. Number 8, change compressors every 2 minutes. But you can do it sooner if you get too tired to continue. Number 9, do not hyperventilate this patient. Do not hyperventilate. Do not hyperventilate the patient. Yes, that is high quality CPR for pediatrics. Feel free to interject if you have any question. So we have SSSC. We've done S, safety, stimulate, shout for help, circulation, check for pulse and breathing. We're left with ABD. Now, A is for airway. If we are talking about an infant, we want them in the neutral position. Neutral position. If we are talking about a child, then we want to have them in the sniffing position. So sniffing position. B is for breathing. At breathing, we said if there's no pulse or it is less than 60, then we are doing CPR. If you're one rescuer, give 2 breaths after 30 compressions. If you are 2 rescuers or more, give 2 breaths after 15 compressions. If pulse is greater than 60, but they are not breathing, then you want to give 1 breath every 2 to 3 seconds. Okay. Now, who do you give a breath every 2 seconds? The infant. The younger they are, the more breaths they need. So the infant, 1 breath every 2 seconds. The child, possibly 1 breath every 3 seconds. If they are intubated, one breath every 2 to 3 seconds as well. D is for defibrillation. Here, we are using an AED in BLS, and the first step to operating the AED is to power it on and then to follow the prompts, okay? Now, if you're dealing with someone greater than or equal to 8 years, use adult mode. So if your AED has a pediatric mode and an adult mode, anyone more than 8 years old, use the adult mode plus adult pads. Less than 8 years, use the pediatric mode. And pediatric pads. But if you don't have an AED that is pediatric capable, it doesn't have a pediatric mode, doesn't have pediatric pads, go ahead and use the adult mode, adult pads, okay? Now, if they are less than 1 year, a manual defib is preferred. A manual defibrillator is preferred because it allows us to calculate the energy we are giving based on the infant's weight. Any question on pediatric BLS? So, Daniel, how do we relieve choking in a child if they are responsive? Daniel, are you there?
So, it's called the Helmich maneuver.
The Heimlich. So you kneel behind them and you attempt the abdominal thrust until the object comes out, or they become unresponsive. What about the infant?
I'm not sure about the infant.
Ruth, infant, responsive. Thank you, Daniel.
Back slabs.
Back slaps, how many?
5.
5 back slaps, 1 per second, alternating with?
The chest thrusts.
Yes, 5 chest thrusts. So 5 back blows, alternating with 5 chest thrusts until the object comes out or they become unresponsive. If the choking infant or child becomes unresponsive, firm flat surface, shout for help, start CPR, beginning with chest compressions. Any question on basic life support or a concept we've watched and is not clear, you would wish for us to clarify?
I have a question. So for the infant, if you don't have a manual defibrillator, what do you do?
You can use the AED. You can use the
With
AED.
the pediatric
Now,
one?
yes, you'd use the pediatric mode. But even if the pediatric mode is unavailable, you'd use the adult mode. Pad placement would still be antero-posterior. So whenever you're using adult pads on anyone less than 8 years old, pad placement is antero-posterior. Then you follow the prompts. Now, it's quite rare for pediatric patients to have cardiac issues because the commonest cause of collapse in pediatrics is respiratory issues, shock. But use
So
the
if you're using the adult one, the kilojoules are
max.
extraordinarily high.
They are. But now, it's the only remedy to terminate an abnormal heart rhythm, and it's all you have. What will you do? You'd rather deal with the consequences or the sequelae after you have saved that life, as opposed to doing nothing and losing that life.
Okay.
Yeah. Any other question? Okay. So let us now shift gears to pediatric advanced life support. Edgar, are you in a position to play the videos? Can't see. Okay. Let me see if I can cue some videos for you guys shortly.
In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. And of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording. Welcome to the Pediatric Systematic Assessment video. In this video, we will focus on evaluating your patient, identifying the presenting problem, and providing appropriate interventions. Once you've performed the interventions, you'll repeat the process by reevaluating the patient and identifying whether the problem has resolved or worsened. Then you'll apply additional interventions as appropriate. Because the child's condition can change rapidly, you'll need to repeat the Evaluate, Identify, Intervene sequence, or EII, frequently throughout the assessment process. The first step in systematic approach is the initial assessment. It's what you first see and hear when you immediately encounter the child before you touch the child. You'll quickly observe the child's appearance, breathing, and circulation. This will determine your next actions. The Pediatric Assessment Triangle, or PAT, is a memory aid to help you recall the components of the initial across-the-room assessment.
The first thing you'll observe is the child's appearance. This includes his level of consciousness and ability to interact. If the child's unresponsive, You should shout for nearby help and then activate the emergency response system. Then you should check breathing and pulse and provide rescue breathing or CPR if needed. The next part of the pediatric assessment triangle is evaluation of work of breathing. Is there an increase or decrease in rate or effort? Is it normal? Or are there audible respiratory sounds? After breathing, you want to look at circulation, which will tell you how well the child is perfusing. This includes skin color and pattern or obvious significant bleeding. Always remember, it's a life-threatening condition if the child is unresponsive or apneic, has inadequate or labored breathing, or is mottled, gray, pale, or cyanotic. You'd want to immediately call for help and begin life-saving treatment.
If there's no life-threatening condition, you'll proceed with the primary assessment. But now, let's practice the PAT, the initial assessment. You'll watch a scene that represents an emergency situation you might encounter. Then we'll stop to let you make your initial assessment.
Okay, so we have started pediatric advanced life support. Essentially, one of the things we must have at the back of our minds as we are starting this topic on assessment is the cycle. So according to the PULSE approach, we have evaluate, identify, intervene. And then, of course, you re-evaluate. Now, when it comes to evaluation, we are saying you can do an initial assessment. Your initial assessment is just so that you identify whether or not there's a life threat. So if appearance is hindered, so level of consciousness is altered, that tells you that's a very sick child. You need to activate emergency medical services. If the child is in severe respiratory distress or they are in respiratory failure, okay, you need to activate emergency response team. If the child has mottled skin, cyanosis, okay, in addition to other things, it tells you there's a life threat, you need to activate emergency medical services. So the initial assessment just basically highlights to you how severely ill the child is and the need for immediate intervention. So if I find severe respiratory distress, then the immediate intervention would be to put this child or infant on oxygen, as well as connect them urgently to a cardiac monitor and ascertain what I'm dealing with. Another point of evaluation is the primary assessment, which we will discuss shortly. So there's the initial assessment, and then the primary assessment, and then there's the secondary assessment. Now, what you're trying to identify is, am I dealing with a respiratory issue? So it could be respiratory, and respiratory could be caused by different things. Respiratory issue could be as a result of an upper airway obstruction. It could be caused by a lower airway obstruction. It could be caused by a lung tissue disease, or it could be an issue of the central nervous system. So disordered control of breathing. And these issues could be in terms of severity. The patient could be in terms of staging. They could be in distress. So they could be in respiratory distress, or they could be in respiratory failure. Now, the other possible challenge would be circulatory issues. So circulatory issues, and we are primarily concerned about shock. So is it anaphylactic? So is it hypovolemic? That's the most common. Is it distributive? And under distributive, then we have your anaphylactic, we have our septic, we have our neurogenic. Could it be cardiogenic? Could it be obstructive? And in terms of severity, you could have compensated, or you could have hypotensive. So right from your evaluation, you identify. The other possible issue could be arrhythmias. Let me write it that way. Arrhythmias. So already you are trying to check which pathway am I on? Which pathway is this child on that could lead to a cardiac arrest? So early recognition and prevention of the cardiac arrest. So evaluate, identify, and that will allow you to then intervene. Because if we know it's a lower airway obstruction, even before we know exactly what is causing it, we are able to know that we need to give bronchodilators, possibly, okay? If we know it is an upper airway obstruction, even before we know what exactly is causing it, depending on the severity, we know possibly we need to nebulize with epinephrine, okay? We know if it's a lung tissue disease. Now, if it's unilateral, maybe crackles are on one side, then we know possibly it's a pneumonia. We need to prioritize antibiotics. In the meantime, possibly we need to do continuous positive airway pressure. If it's bilateral, then definitely we need CPAP or BiPAP, all right? We know if it's a circulatory issue, hypovolemic fluids, okay? Even if it's distributive but hypotensive, we need fluids. Even if it's cardiogenic but hypotensive, we need fluids, only a little less, and we need to consider the inotropes, okay? If it's obstructive, say it's a tension pneumo, we know we need to do needle decompression. So evaluation forms the key to you being able to identify and then intervene. So the first step in evaluation is the initial assessment. And the initial assessment is done using pediatric assessment triangle, ABC. So A is for appearance. And this is where we are able to identify critically ill patients off the bat. So what we check for is the tone. How is the tone? How is the interactiveness of this child? Are they consolable? How is their look or gaze? And how is their speech or cry? Are there sounds. Okay, so this is summarized as tickles. The tickles mnemonic. That is what we use. Tone interactiveness, consolability, look or gaze, speech or cry. So if you realize reduced tone, reduced interactiveness, look or gaze is fixed, you need to activate the emergency response team immediately. B is for breathing. Here, what you want to appreciate, because the initial assessment is what you can see. What you can see within the first 10 seconds. So breathing, we would be able to appreciate the positioning of the victim or child or infant. We would be able to appreciate if there's increased work of breathing. So increased work of breathing here, we are talking about, do they look tachypneic? Use of accessory muscles. Things like head bobbing, which would be a consequence of use of accessory muscles. Nasoflaring, are those present? So that, and retractions, so that I'm able to say, oh, there's increased work of breathing. Now, depending on the severity, I'm already thinking I want to put my patient on oxygen, okay, based on work of breathing. So look at the work of breathing. Are there any sounds as well? So sounds, added audible sounds. So if they have audible sounds, then you know that there's a problem. C is for circulation. And here, all we need to do is check the color of the patient. They have pallor. Has it graduated to cyanosis? Do they have mottling? That tells you there's a problem. So you do an initial assessment, and that allows you to categorize this patient as severely ill or not severely ill. The severely ill child is at risk of a cardiac arrest, imminent. Activate the emergency response team. The not so severely ill child, we can then take our time and proceed to our primary assessment. So before we do our primary assessment, I then want us to have a look at some cases here and then tell me what you would do for these patients. So we'll start with Daniel and then Ruth. So let me just pull up the videos. Okay. Share. Video share. All right. So Daniel, you're there?
Yes, I am.
Okay. So there is the baby. What's your take? Initial assessment.
Okay, so initial assessment in terms of appearance. I can say okay, I've not mastered the tickles, but okay. In terms of the breathing, I can see he appears to be tachypnic.
So let's start with the appearance.
Yeah.
Start with the tone. Is the tone appropriate?
So the tone is appropriate for the age.
It is. You expect a child this age to be lying completely still?
Not really.
When they are awake.
They should be moving around.
Yes.
In terms of the tone, I don't expect the flexion, etc.
Yeah, so the tone is reduced.
Okay.
So there's reduced tone.
Uh-huh.
The I was for what?
Mm-hmm.
Inconsolability.
Consolability.
Tickles. No, that's the C.
Oh.
The I was for? There's tone, then interactiveness. Is this child interactive from your assessment?
No, he's not. She is not.
So there's reduced interactiveness. Consolability, we can't tell because they are not crying. What about the look or gaze? How is it? Is it appropriate?
The look of the gaze is not appropriate.
So there's a problem at appearance. There's a reduced level of consciousness. What do you want to do if not already done? This is a patient at your OPD. Question is this a severely ill child, Daniel?
Yes.
So what do you want to do? Ruth, what do we do?
Baby like this, we want to maintain. Now we go to your ABCs and you make sure
You haven't yet
secure the
gotten to your
airway.
ABCs. You haven't yet gotten to the primary assessment. Will you need help?
You'll definitely need help.
So what do you need to do?
You call
need to
for help.
activate, yes. So you need to call for help. Okay. Daniel, we are back to you. So appearance has triggered us to call for help. What other area are we assessing in this child?
To breathing. So he appears to be having, let me say, tachypnea.
Tachypnea?
Outlook, but of course I'm not counting the rates. And then also some in drawing.
In drawing, so retractions?
Yeah, retractions. And also, if I may say, in terms of the devices, he's attached to oxygen.
So let's say they were not attached. What would that necessitate?
That would necessitate giving oxygen depending on the needs of the child.
We don't yet know the needs, but even before we know the needs, we start them on oxygen.
Exactly.
Yeah, if this child,
I meant like, of course, you cannot, depending on, for example, if the CO2 is like at around 85, 86, you can give it through the nasal cannula.
We don't yet know the saturation levels. That's what I meant as well.
Okay,
so we are yet to establish their SpO2. But regardless, we start them on oxygen. Hyperoxia is definitely less lethal compared to hypoxia, right?
True.
Yeah, so you start them on oxygen. Depending on the severity of their respiratory distress, you can even do 15 liters via non-rebreather. So you start them on oxygen, and then immediately you want to attach them on a cardiac monitor and do pulse oximetry so that you titrate your saturations, your supplementation to the oxygen levels of the patient. What about color? Tell us about color. How is the color?
The color, the child is okay. I can say mottled.
Mm-hmm.
Yeah, I can say mottled and appearing pale.
Which part is mottled? Which part?
The abdomen.
Is it pallor or mottling?
I can say mottling. The abdomen.
Okay, maybe the feet down here, but the abdomen is pale actually. So there's pallor, but it's hard to appreciate on a screen, on a video recording like this one. Okay, so that's a severely ill child. Daniel, is that right?
That's right. This is a severely ill child.
And we need to immediately activate EMS and get the patient on oxygen. Okay, Ruth, this is your patient. Tell us what you see. So?
Please repeat it.
Uh-huh.
Okay, so tone. I think baby's tone is okay, normal tone, able to open the mouth, able to maintain their posture, like seated upright. Interactiveness, baby seems to be interactive, is accepting to get the thermometer in the mouth. Consolability, I don't think we can. Okay, baby's not overtly crying, not looking overtly irritable, so I don't think baby is inconsolable.
Yeah.
Look or gaze, baby seems to be staring at the healthcare provider.
Yeah.
Speech or cry, we can't elicit.
So appearance is good.
I would say so.
Uh-huh. Work of breathing?
I'm not seeing increased effort.
Okay. So there's no increased work of breathing. Color?
From the skin, baby seems to be good. From the tongue, I wasn't sure if I'm seeing a pink tongue or if I'm seeing a slightly cyanosed tongue. I wasn't too clear on the color.
Okay. So does this baby or child need urgent intervention necessitating activation of the emergency response team?
Not in the acute setup that I'm seeing right now.
So you would then proceed with which assessment?
I would still do my primary
assessment. So
Yes.
this child is in a state where, based on our initial assessment, we can progress and do a primary assessment. We can progress and do a primary assessment. Okay. Daniel, one more. Oh, okay. Daniel says he's listening in. I think he's engaged. So I think that leaves you, Ruth. So Ruth, tell us about this next child.
Wow. Okay. So, on our tone, we seem to have reduced muscle tone. We barely have any movement going on.
Could it be that the baby is asleep?
It is possible, however,
Baby is asleep. This baby is asleep.
Could be asleep or could have a reduced state of consciousness.
Okay. All right, fine. So let's say we are unable to assess appearance on screen unless we were close by and created a commotion, right?
Yes.
Okay. So draw on that one. Now, breathing. Is there anything you feel or hear?
Yes, I can hear a stridor.
An inspiratory stridor.
Yes.
What about the chest?
Wait. We have an increased rate. We have use of abdominal muscles. We seem to have a lower chest wall in drawing.
So there's increased work of breathing.
Yes.
All right. So possibly needs oxygen. Color.
Not too sure if this baby is looking pale. I can appreciate the skin looking a bit flushed, but baby looks low-key pale.
So let's say for now, unless we had the baby with us, we can't really assess properly. Yeah. So I now want us to do the second video for assessment, the primary assessment. The primary assessment, and then we'll see. We might take a break after discussing and then come back. So let me play the primary assessment.
A, B, C, D, E assessment. And you'll assess the child's airway, breathing, circulation, disability, and exposure. We'll start with the airway and breathing sections of the primary assessment.
Now, the first thing you want to do is determine if the upper airway is patent and maintainable.
Now that we've practiced the initial assessment, let's move on to the primary assessment. This is a rapid hands-on A, B, C, D, E assessment, and you'll assess the child's airway, breathing, circulation, disability, and exposure. We'll start with the airway and breathing sections of the primary assessment.
Now, the first thing you want to do is determine if the upper airway is patent and maintainable. Maintainable means that the airway can be kept patent or maintained with simple measures like positioning, suctioning, or insertion of an oropharyngeal airway, or an OPA. Now, in an unresponsive child, open the airway by using the head tilt chin lift maneuver. You place one hand on the child's forehead and push with your palm to tilt the head back. At the same time, place the fingers of the other hand under the bony part of the lower jaw near the chin. You lift the jaw to bring the chin forward. This will lift the child's tongue, relieving a possible airway obstruction. Do not use your thumb to lift the chin, and do not press deeply into the soft tissue under the chin because this might block the airway.
If the airway isn't patent or can't be made patent by using simple maneuvers, you'll need to insert an advanced airway.
If you recognize that the airway is patent, assess breathing. And to do that, you need to evaluate several aspects of the child's respiratory function. Is his breathing pattern regular? What about the respiratory rate? Is that normal for his age? If not, is it too fast or too slow? What about the child's effort? Is that normal? Are there signs of increased effort, such as nasal flaring, head bobbing, chest retractions, or seesaw respirations? And if you see any of these signs of increased effort, do they occur during inspiration, expiration, or both? Do you hear any grossly audible sounds, such as stridor, barking cough, or snoring? Is he grunting? You have to make sure to take all of these into consideration.
When checking a child's breathing, one of the key things you want to assess is chest expansion. Look for chest rise and fall with respirations. Chest expansion should be equal on both sides. Also look for prolonged inspiration and prolonged expiration. This is the time it takes the child to exhale. It typically represents lower airway obstruction, such as seen with asthma.
Now, using a stethoscope, listen to the following areas: front of the chest, just to the left and right of the sternum, under each axilla, and both sides of the back. Is the air movement normal or decreased? Compare breath sounds on the left side to those on the right, and compare sounds in the front to those in the back. Listen for abnormal sounds, such as wheezes or crackles, and determine if air movement is normal, decreased, or unequal. Here's a clip of a real patient in respiratory distress. Note the expiratory wheezes along with a rapid respiratory rate and increased respiratory effort.
Pulse oximetry generally gives an accurate estimate of hemoglobin oxygen saturation, but does not provide evidence of oxygen delivery. It also does not provide information about carbon dioxide elimination, which is referred to as ventilation. Now, during shock and cardiac arrest, systemic blood flow is severely compromised, and for a pulse oximeter to calculate the hemoglobin saturation with oxygen, it needs to detect pulsatile blood flow. If the child's pulses are extremely weak, the pulse oximeter may not be able to detect the hemoglobin saturation, or the results may be inaccurate. And remember, your focus should be on supporting and treating the child, not the device. If the oxygen saturation is less than 94% when the child is breathing room air, this indicates hypoxemia.
If the child is in respiratory distress, identify whether it's mild or severe. The following signs indicate that the child is in severe distress and may progress to respiratory failure, so the child requires immediate care. Decreased level of consciousness, very rapid or inadequate respiratory rate, significantly increased or inadequate respiratory effort, and low oxygen saturation or cyanosis, despite high concentration oxygen. Children with respiratory distress usually have an increased pulse rate. If a child in respiratory failure develops bradycardia, this is a sign of impending cardiac arrest. Call for help immediately. Then open the airway. Be prepared to provide bag mask ventilation.
Now that we've discussed airway and breathing, let's discuss CDE, the circulation, disability, and exposure components of the primary assessment. To assess circulation, you'll check the heart rate and rhythm, pulses, capillary refill time, skin color and temperature, and blood pressure.
The assessment of heart rate is very important when evaluating a child's circulation. Alterations in a child's heart rate can provide significant clues to the severity of illness or injury and response to treatment. Age and a number of clinical conditions can affect a child's heart rate. When evaluating the heart rate, first consider if it's normal for age. Anxiety, pain, agitation, or fever can all increase the heart rate above normal. If the heart rate is less than 60 beats per minute with signs of poor perfusion, despite adequate oxygenation and ventilation, you must provide CPR immediately. Feel the central pulses, such as the carotid or femoral in a child, or brachial in an infant. Also feel the peripheral pulses, such as the radial pulse. Another sign of poor perfusion may be capillary refill. Normal capillary refill time is 2 seconds or less. However, delayed capillary refill time is not always abnormal. Other important assessments of perfusion include skin color and temperature. Look to see if the skin is pale or mottled. Note if the skin is warm or cool. Look for cyanosis in the skin, nail beds, and mucous membranes. And compare the color and palpable temperature of the trunk with the color and temperature of the extremities. When the child develops poor perfusion, the hands and feet may become much cooler than the trunk.
The final component of circulation assessment is blood pressure. When you're measuring the blood pressure, the length of the cuff should extend to cover at least 50 to 75% of the upper arm, from the axilla to the antecubital fossa. In addition, the bladder inside the cuff should cover no more than about 40% of the mid-upper arm circumference. A cuff that's too large will give falsely low values, and a cuff that's too small will give falsely high values. Take note of whether the systolic blood pressure is normal or abnormal for children 1 to 10 years old by using the following formula. The normal systolic blood pressure for children 1 to 10 years of age is about 90 millimeters of mercury, plus 2 times the child's age in years. Hypotension for children 1 to 10 years of age is a systolic blood pressure of less than 70 millimeters of mercury, plus 2 times their age in years. If you can't palpate distal pulses, the automated blood pressure device may not accurately measure the blood pressure. In addition, automated blood pressure cuffs may provide inaccurately high readings when the child's in shock. And for this reason, if the child's in shock, an arterial catheter is often inserted to monitor the child's intra-arterial pressure. This intra-arterial pressure measurement should be very accurate if the system is properly set up and the catheter is patent.
It's important to know that children can be in shock but still have a normal blood pressure. Hypotension is usually a late sign of shock, so you want to intervene well in advance of this. Otherwise, they deteriorate very rapidly. It's scary how quickly it can happen.
Now that we've discussed circulation, let's move on to the next step of the primary assessment, disability. This entails assessing the child's level of consciousness, pupillary responses, and glucose.
To assess a child's level of consciousness, we use the AVPU, or AVPU, Pediatric Response Scale. This is a mnemonic you can refer to when assessing a child's level of alertness and response to stimuli. Is the child alert, responsive to voice, only responsive to pain, or unresponsive? If the child does not respond to voice, assess the child's response to a painful stimulus, such as a sternal rub. 2 other quick assessments are pupillary response and glucose level. When performing a pupil check, we'll check for size, symmetry, and reaction to light. Unequal pupils may suggest a serious problem, such as increased intracranial pressure or an eye injury. Normally, the pupils rapidly constrict in response to light. In addition, if you shine a light into one eye, the other eye should normally constrict, and this is called consensual constriction. Slow constriction or no constriction may indicate increased intracranial pressure. If one or both pupils are dilated, particularly if they don't react to light, the child may have a severe and life-threatening increase in intracranial pressure and require immediate evaluation and treatment.